Hi everyone, my name is Neeraj Shah. Um, the case that I'm presenting is a 64-year-old lady who basically she has a history of end-stage renal disease on dialysis, hypertension, dyslipidemia. She had a CVA in May of 2017 without any residual deficits. She presented as an ambulatory patient for a cardiac cath. Her complaints were dizziness and intermittent non-exertional chest pain, and she had an outpatient SPECT MPI which showed a new decrease in her ejection fraction to 32% with a fixed apical defect. Unfortunately, as she was walking to the registration area, she had ambulatory dysfunction at baseline, but as she was walking to the registration area with her aid, she fell, and she was complaining of left hip pain, and she had a X-ray which showed that she had sustained a left femoral neck displaced fracture even before she arrived to the cath lab. On exam, the patient was in distress because of her left hip pain. Otherwise, the exam was unremarkable. She had a left upper extremity AV fistula, and she had a non-palpable right radial pulse. Given the fact that she had a newly diagnosed cardiomyopathy with abnormal perfusion, and she was probably going to need some surgery for her hip fracture, we decided to go ahead and perform a diagnostic left heart cath via right femoral artery approach. This was her ECG on presentation, really unremarkable. And the left heart cath, the hemodynamics, her LV pressure, there was no gradient between the LV and AO. She did have a 15 to 20 millimeter gradient between her central aortic pressure and her right arm BP cuff pressure, suggesting some degree of possible right subclavian stenosis. And this were her cath films. So she has this tight proximal LED calcified stenosis that we see in this view, and in this view as well, right here. And she has a very tight mid RC, almost 95%, again calcific stenosis. And this is her LV left ventriculogram, which shows the diffuse reduced ejection fraction. EF was around 35%. So the question is what we would do at this point. And this lady who has sustained a recent hip fracture, she needs surgery, otherwise she would have been not able to walk. But she has critical CAD in two vessels, in her LAD as well as RCA.
And LV dysfunction.
And
every predictor. The only was that patient has a limited pharmacological or Reg-Darson that test showed apical
Fixed defect.
Fixed defect. But patient has LV dysfunction, with all that led to the angiogram, and we said, clearly first thing we want to do, this one, that girl asked the orthopedic that,
yes,
take her. And with the surgery, and of course with this kind of anatomy, question is, can we clear it, and then how much time we have? So they told us that with this fracture, you have 48 hours.
Wow.
So we need to do surgery within 48 hours. So you have whatever you want to decide, it's a 48, 72 hour window, and then otherwise it will develop aseptic, whatever, vascular necrosis, then will be the complete replacement after a month or so, and that's a totally different ball game compared to restore the current hip joints. Yeah.
And nobody would take her to the OR with a proximal LAD, tight
Once you-
LAD,
yeah.
and that tight right.
Once
So
you
now
look,
what's-
I mean.
What do you do?
Once you
Well,
look.
you look.
You may get lucky. If you were doing FFR of the LAD, do you think that's a reasonable approach? What if it came back 0.85? Would you say, oh, we're still going to do the LAD, or would you then say, oh, thank you, God, we're just going to focus on the right?
Or not do the right.
Yes, or not do the right.
And just go to surgery because the LAD is open.
No, but surgery, which surgery?
Hip.
Oh, no, we already called the ortho, we called
Right,
the anesthesia.
that's what we're
Anesthesia said
asking.
Patient cannot go for surgery.
Yeah.
So we called the patient on the table.
Unless you
ortho.
open the right or the, what if the FFR was negative though? In the LAD is what David is asking. I think it's a nice question.
No, but,
FFR the LED?
yeah, okay, but you still have to deal with the, let's say FFR negative of the LED.
Get the right.
Look at the right.
No, I think the right,
So
that-
you have to
that-
take
then it's
care.
a different question,
It's still-
though.
Okay, let
yeah,
us.
yeah, clear.
The right is pretty ugly.
Yeah, and I wonder if this is supplying the
It
apex.
looks, it looks kind of,
Cut off,
unstable.
like us, yeah.
It does,
you know, it has that like Ambrose type lesion looking thing.
So we actually tried to, I had a patient about, this happened, 1 or 2 months ago, a week before, non-STEMI, evolving non-STEMI, has a limb salvage issue, and the same situation. So we had a ISR. We did the PTCA only, didn't even put a stent. After Rota PTCA, sent the patient for surgery about 5 days later, and after the vascular surgery, patient arrested and died that night.
Oh.
God, right.
Yeah, I mean, that's the risk,
That was
right?
PTCA, not a stent.
Yeah. I mean, you know, we talk a lot about the CARP trial, which is the randomized trial of revascularization before non-cardiac surgery, and I think, you know, this patient would not have gotten into that trial.
No,
I mean,
exactly.
It's an emergency surgery. The patient is obviously has a lot of comorbidities. The coronary disease burden here is ridiculous. So what the surgeons are worried about is what are the chances this patient either dies or has an MI post-op. And the chances are very high. This is a very high-risk patient. So in the absence of any good randomized data, I think you have to do something. The question is, what do you do?
Yeah.
Go to your next.
So these are the options. What do? We don't do anything, let her go for surgery, very high risk of cardiac events. Not let her go for surgery, she'll have ambulatory dysfunction. So I don't think those two are the options. We stent the LAD and RCA, but then we'll have to defer the surgery by at least 30 days. We stent that and perform the surgery on dual antiplatelet, very high risk of bleeding. We just do a balloon angioplasty of the LAD and RCA, but in that case, we'll have to wait for 14 days unless they let us continue aspirin.
Yes.
And what about this option, use of IV cangrelor as a bridge?
So I'll give you my own opinion about bridging. You know, I think the challenge with bridging is that if you look at the stent thrombosis events, most of them, if not all of them, occur post-op, not pre-op. So I've never really understood the use of bridging pre-operatively, because that's not when the stent thrombosis occurs. It occurs post-op. Now, could you use cangrelor post-op? I don't know. I mean, you know, I don't know of any data that suggests that that's either safe or effective. But using it pre-op, I don't know. I've never really sort of thought that that would be of any benefit. Personally.
So we had the discussion with the orthopedic surgeons, and they were comfortable doing the surgery on aspirin.
Yes, they should.
yeah.
They should. They should.
So based on this and
And
based
the
on
risk
the
of
fact,
stent thrombosis isn't going to be super high. Remember, even in the STARS trial, when people were randomized to aspirin, the stent thrombosis rate was like 3% or something like that. It wasn't 100%, 3.
Right.
So I think it's very reasonable that the surgeons do it on aspirin and that you proceed in that direction.
so based on that and based on the fact that she needed something done for her hip in the next 2 or 3 days,
Yeah.
we decided to proceed.
But this whole thing of bare stent versus, you know, we should use bare stents because of, you know, and I think what the most important thing is that if you are going to stent, get the best absolute optimal result. Use intravascular imaging to make sure that so it doesn't matter if it's drug versus bare stent. I think we don't really have a clear evidence to say that DES is worse in this setting. So of course, this setting has never been studied, so nobody knows, and I think people go for the bare stent, but I think, you know, the idea of just getting the best optimal result during the time of PCI is the most important in the case like this.
So we
So let's see what you do.
Yeah,
I
we
mean, so
decided-
if you put a DES, it's okay.
No, we actually decided that we would perform rotational atherectomy and PTCA only
Of the right.
of both the
Of both.
LAD
Oh,
and the
okay.
RCA. Let her undergo the surgery because it was time contingent, and then have her come back whenever she's stable post-op
It's
to
not
stent
bad.
those lesions.
Nice choice.
So we ended up using a 1.5 burr in the RCA, in the mid RCA, and a 1.75 burr in the proximal LAD, and then we did PTCA of the RCA with a 3.020 NC balloon and a 3.515 NC balloon in the LAD. We actually did start the patient on cangrelor post PCI, and the plan was to hold the infusion 2 hours before surgery. And baby aspirin, like I said, was continued in the perioperative period. And after discussion with the orthopedic team, it was decided that we'll start. They were not comfortable starting Plavix right away, so they were comfortable starting it 4 days post-op.
So here it actually makes sense because what you're not trying to, I mean, what you're trying to do is make sure that your PCI result stays open. So in a way, you're using cangrelor, I mean, there's no stents, right? So it's not stent thrombosis. This is not an elective patient who comes in, you know. So I think cangrelor here makes a lot of sense. And I think the use of the burr here is important because if you had gone in with just balloon angioplasty and you had dissected the whole thing, now you're stuck. Right, now you're stuck.
Now you're
you got
putting
you have
lots
to
of
do
stents
something.
in.
And so I think the use of rotablator here is actually, it's a really good choice.
So this is what we did. This is the road. We bought the LAD, and this is the
Did you
final.
load her again?
No,
No.
No,
Just
just
Flavisamol.
75 milligrams. And then
What did
this.
you use during the procedure?
not just Cangrelor and aspirin.
So Cangalor was started at the time of
Yeah.
Rhoda.
There's a dissection
It's
there.
small
which is-
There is a little
we're
linear
dilating.
dissection.
So that did, for
Yeah,
10,
yeah, but
15
this
minutes,
is,
keep it.
Yeah.
this is okay, right?
Pretty good balloon result.
Yeah. And there's another rota. Look at the right one.
Holy Sharma.
And this is post PDCA of the RCA.
Beautiful.
Nice.
I would like
In
to
the
see.
old days, we'll be very happy with
I'd
this.
love to see the ventricular function in a couple weeks to see how much recovery.
Yeah. So with this patient, actually, we did post surgery. Her initial echo was not done at Sinai, was done outside the PC. So it was about 35%. It went up to 42. She had a surgery, but actually 48 hours.
Mhm.
And then while recovering,
Mhm.
we started Plavix. So because with the all hip issues and so,
Yeah.
now she developed CVA.
Yeah. So she
on those
basically.
7 or 8 days.
Yeah.
Yeah.
So on
If
post
you're
op
on Plavix, you'll not have.
post op
No,
day
no,
3.
not yet, not yet.
Yeah.
You said, you said,
Fourth day we started.
Yeah.
ah, you
fourth day
did
we
start it
started.
on the fourth day, sorry.
Yep.
Yeah. And that episode of CA was related. She had an episode of
was her
hypotension
problem
while she was
all
in
the
the
way
in the
around.
ICU in the CCU,
Yeah,
and she did have significant.
But they knew the carotid. Right?
This was not known before.
But
So-
we
so-
knew she had a history of CVA, she had
She
just.
had dizziness and she
She had
fall and break her
dizziness, she
hips.
falls.
Yeah.
Moral of the story.
Yeah.
And
Don't let
maybe-
them walk.
And maybe little hypo
Yeah,
happened with
hypo,
RCA. I mean, we don't know what,
Yeah.
where
She had
is the
watershed.
The
event.
No, but the-
hypotension and
She stood up because what happened, they brought her from downstairs on the
Gurney.
wheelchair.
Wheelchair, yeah.
And the daughter, so this is before we patient registered in. So from
Hmm.
medical legal point of view, you know,
Yeah.
it's like, what happens if the patient is going out of your office and drop dead on the door? You just change
Turn
the
him around.
direction. Turn it around as it's just coming in. So we didn't need to do anything for this particular case. Yeah. So this happened before the patient was registered, and all these things happened. So clearly, one that I'm sure coronary has to be something to do along with the
think
carotid disease.
the
on this
carotid
particular case.
disease
Yeah.
was the
Yeah. So then patient, they did.
history of CVA, a little
Yeah.
bit of confusion, a little bit of dizziness, a little bit of this and that. That was like her main risk factor.
And actually, our plan was to do the PCI.
And then do a
stent,
carotid.
I mean, before discharge. No, I mean, this CVA then took over everything.
Yeah,
of
Hemodynamically, she did fine.
Mm.
So we just let
Oh,
her
so
to
she's
discharge what we
completely
had.
recovered.
Yeah.
Yes, she recovered
She
completely
recovered.
from the
Oh,
CVA.
thank
So
God.
we are
Oh,
just
that's
waiting
good.
now. Our classical neuro, we'd say if stable CVA post
Yeah.
cath, you do a PCI, wait 3 months. That's the neurologist recommend. So we are waiting for the 3rd month, which will be next month. to do.
Oh, so you did do
Don't mess with it.
the carotid
The
stent? was
neurosurgery
amazing.
did that.
That was good.
Neurosurgeon did the carotid stent.
That's great.
So
That's
that actually
good.
made very rapid recovery on her.
So
Nice
that was
case.
the
The patient
acute
was in
stroke.
CCU,
Yeah.
did very good.
Stent.
Rapid recovery with the stenting in the carotid.
Wow,
It's a nice case.
that's
They
a
did
nice
that, yeah.
case.
Yeah.
So now coronary is
This is
still
a
with
great
that
case.
rota
You want it for
PTCA.
Jack and
Yeah.
That is the only thing. So what is there inside, we don't know yet.
Yeah, that
We don't know
maybe,
yet.
maybe a nuclear
But
stress
she
test or
went through all
something.
this.
Just let her be, as
From
Yeah,
says,
the
leave her
carotid point
alone.
of
Very
view, she
strong,
went
exactly.
straight.
Let her
Exactly.
be now. Just let her be. She's good.
Can I ask
She's
a question?
happy.
Had we known about the carotid before the surgery?
Before the hip
Before the
surgery.
hip surgery, we identified a critical carotid stenosis.
Yeah.
That would have raised our pre-op evaluation immensely. There's nothing we would have done about that. I mean, so her chances of having a stroke post-op were probably the same.
Yeah. Great.
And would the surgeons have said, okay, we'll accept a stroke, but not a heart attack? You know,
No,
I-
because they
I'm just
didn't
thinking
know.
about
They
the
didn't know.
process
Because they
of
didn't
thought
know.
here.
didn't know.
If they knew about the stroke, they would say, "Oh, you gotta fix
We're
that
done.
too.
Medical
Fix
therapy.
that too." Yeah, before you
no.
come to us, or figure that out before you come to us. I think if they would have said revascularization
But
of
there's
both
nothing
of
we could
those
have done
before you.
about this in 48 hours, like we could for coronary.
No, you put a stent in.
Well, you have to do antiplatelet.
Yeah,
Yeah, but it's usually not a problem because it's such a large diameter.
such a
vessel,
large
yeah.
diameter. It's not a big deal. Interesting. Great case.
Great case.
All right. Very good.
Real dilemma.
Okay, let's get to our third.